senior band 5s get a promotion into to senior roles, as in so they've gone from band 5s to band 6s. So they hand their notice in, give 4 weeks notice, but the recruitment process from start to finish within this organisation takes probably 3 to 4 months.
Okay, yeah.
So I've constantly got vacancies.
Right, okay.
And then you've got sickness on top of that. Unfortunately, due to financial pressures, community nursing, there was some hours removed from my budget for qualified nurses, which has been really detrimental to my team, my staff. I've got staff working extra to meet demand. Because of the care closer to home vision was that we'd have this self-care model and push forward with it. With this area in particular, which is one of the most deprived areas in North East Essex, and that's with it. That's one of my wards that I cover. So primarily JRIC. Patients are not. They don't self-care.
No.
They're at the age. They're vulnerable. They haven't got the knowledge or skills or had the education to understand that. Unfortunately, nursing has been driven up till now, or more recently, the last 18 months, that nurses go in and do. The perception out there, when a patient gets referred to us, their GP, their consultant has told them the nurses will come into them and do this for them. So it's breaking those barriers, which we're starting to do.
Yeah.
But when we do have those conversations, we get complaints coming. So to answer your question, from a vision, from a care close to home point of view, they would thought that referrals wouldn't stay on as long because we'd promote self-care and get these patients self-care in. However, the demand in this area and the practice population isn't allowing us to do that as quickly as we would like.
Yeah, okay. So it was almost written into the contract and the service that because there would be an element of self-care, that would reduce activity and so your finances would be reduced.
Yes.
So what you're saying is that because of the because of various reasons, because of the deprivation in the area and the expectation that patients hold,
the vulnerability.
I'll ask you a little bit more about that in a second.
Yeah.
But, so because they aren't able to self-care, they have reduced the service, but the same level of demand's there.
Yes.
So that's the issue, is it?
Yes, definitely. I mean, I'm not saying there isn't we have moved on within Tender and South locality hugely in the last 18 months of promoting self-care, breaking those barriers, changing nurses' behaviour and perception, because from a nurse you're trained to go in and help patients and do. So we're having, with that health coaching training we've all had, we've had to turn that conversation, have completely different conversations from the outset. So there is an element within our team that we've managed those that can self-care, that we feel that the risk assessment's in place, that they can self-care, been given the training, the education to ultimately self-care does happen. But the percentage on what I feel was probably within the care close to home contract isn't where we're at the moment, and I don't feel that within this locality we will get there.
Yeah, that's actually one of the things I'm really interested in. Actually, is that was there anything in the service that compensated for the fact that there is such a high level of deprivation in your area? Because actually, in one of the original aims in the original strategy, it said about reducing health inequalities, and then that sort of it doesn't seem to get mentioned. And so that's one of the things I'm really interested in finding out about. So, what is it about this locality and the deprivation and the vulnerability that people are experiencing? What are the type of things that are going on in their lives, or that would make it so difficult for them to self-care?
So obviously community nursing visit housebound patients primarily. So they are housebound because their mobility's poor, their eyesight's poor, dexterity's poor. So when we're getting a referral in for a patient that needs to have insulin, there is, obviously I've spoke with my team about, there is aids that you can give these patients, but an 80 to 90 year old lady that's got to administer insulin, who's got riddled with arthritis, got potentially cataracts problems, who is frightened we then start saying you've got to now inject yourself twice a day, and we'll give you all the education and support that's possible for you to do this on your own, and then on top of that understand diabetes and then check their blood glucose levels, which would be pricking their finger and getting a blood sample. However much we try, we've still got a role and we've still got a responsibility to that patient. If they are telling us they can't do it, we try. So that's just one example. They haven't got any family members. You know, in this area we see a lot of vulnerable adults that we ask if they've got any family. They live far away. They don't have visitors from one week to the next sometimes. Or you've got patients that are end of life. That again, referrals to this area for end of life. They've got family that are grieving because their mum, their dad, their nan, their granddad, son, daughter is dying. There isn't much you can hand over to that family. With regards to wound care pressure area, we only get involved when a wound has developed. So we can give them the education and knowledge around that. But if they've then got a relative that can do that, that's great, and that's what all carers. But we then face problems then with care agencies because they haven't had the training to deliver wound care. So there's a multitude of factors of why we're not being able to hand over care to our patients because of their comorbidities really as well. We've got a high level of patients with multiple comorbidities.
And so was the expectation that each area would be able to achieve the same level of self-management, or were any of those factors taken into consideration?
I don't believe it was. I haven't never seen anything that says that. Obviously there was taken into referrals into each service pre-care close to home, and probably they look at referrals in now and they look at time of contact and how long they've been on the caseload. I am not confident that they ever looked at and broke the areas down into what is the practice population, what is the ageing population of that area. You know, I don't think anyone looked at the joint strategic needs assessment to see what is going on out there and what is the aims of each practice population and area. Because I through my district nurse training did a little work around that, and that tells you where the inequalities are, what the aims are, and I'm not confident that was really looked at in great depth.
And so are you able to feed this back to management, the reasons that you're struggling so much to implement this in this area?
Yeah, I obviously sit on one of the self-care working groups, and I will always say, and I've worked within this area, and in particular when I was a junior member of staff within JRIC, so I've got anecdotal information that I know what it's like down in that area, what kind of clientele you're dealing with. So I do feed that back. It goes further that actually there's perception, and my GP told me you're going to do this. So there's lots of barriers. So I do feed that back to management, and it is taken note, and we are obviously trying to work around that.
And so how do you, say you'll get, I think you said before, you go into a home, you don't know what you're going to expect. So there's an idea that you tailor self-management based on your judgments of whether they're capable to do so. And I think in the original documents it talks about using patient activation measures and things like that. Is that anything? Is that used at all, or how would your nurses make how do they make that tailoring decision? What do they look at? I know you said before, somebody with comorbidity with arthritis, they're not going to be able to do it, so they're really obvious signs.
So obviously from community nursing we should be doing holistic assessment. Now holistic assessment to me cannot be done in 30 minutes. Community nursing the time constraints, so where community nursing fall down, particularly in my team at the wayside, is because of our demands and constraints, our holistic assessment doesn't necessarily look like what I would expect holistic assessment is, because to go in and do a holistic assessment on a patient, use your PANS and your EQ5Ds to try and find out what the patient's expectations are, what their concerns are, what their goals are, what they want to achieve. You need a good hour to an hour and a half, and then on top of that you've got the visit that you were there for. So we are all aware of it, and when time allows us to, with a new referral, we will have those conversations with a patient that has got capacity, because you've then got, if a patient hasn't got capacity for the reasons that they've got dementia, a lot of our patients again, our elderly at the age where they've got dementia,